Good afternoon, everyone. Welcome to another PINE session. PINE stands for Pulmonary Infections Network of Experts. It's an early career working group initiative of the Pulmonary Infections and TB Assembly at the American Thoracic Society. During these sessions, we often do interesting cases or journal clubs, which is the case today. We are doing a discussion on the PROMIS trials, which looks at the efficacy and safety of inhaled colistin in patients with non-CF bronchiectasis and pseudomonas colonization. My name is Divya Reddy. I'm an associate professor of medicine at Albert Einstein in New York. Our speaker today is Dr. Farheen Surthie, who's a fantastic third-year pulmonary and critical care fellow at Tulane. I'm very excited to introduce our expert panelists today. We have a tried and tested combination of Dr. James Chalmers, who refers to himself as the dude from Dundee. He also just happens to be a professor in respiratory medicine. We also have Dr. Tim Aksamit, who is a professor of medicine at Mayo Clinic, Rochester. Both of them have been pioneers in the field of bronchiectasis and COPD research. The goal of this conference is to keep it interactive. We do have some audience poll questions. Please feel free to type in any questions that you may have in the chat, and I will try my best to get them answered. So without further ado, I'm going to let Dr. Surthie discuss this publication.
Hi, hello everybody. Thank you so much, Dr. Reddy. So as Dr. Reddy mentioned, I'm Farheen Surthie. I'm a third-year pulmonary critical care fellow at Tulane. So we'll just jump right into it. I'm talking about PROMIS 1 and PROMIS 2. So we'll just go back to just the overview of bronchiectasis. Refers to a heterogeneous group of pulmonary diseases, which is characterized by irreversible damage by dilated bronchi, and it has a broad spectrum of clinical presentations. Some ranging from asymptomatic radiological changes due to when you see them on CT, all the way up to chronic sputum production and recurrent exacerbations. So we'll go into a poll question. So what is the key priority in managing patients with bronchiectasis?
Tiana, can you please show us the results?
Perfect. So preventing recurrent exacerbations is exactly it. And this is why I think this...
Oh, I'm so sorry. I'm so sorry, Farheen. Dr. Chalmers, Dr. Aksamit, do you have any thoughts on priorities in terms of managing patients with bronchiectasis? Are they all, is preventing recurrent exacerbations the most important, or is it a three-pronged approach in terms of managing these patients?
Shall I go first, Tim? I think preventing exacerbations is the most important goal because we know they drive disease progression. I think if you ask a lot of patients what their priority is, it's getting rid of the daily symptoms. And so that's also a really important consideration is patients really care about their cough and their sputum production. And all three of the options, 2, 3, and 4, are part of what we do in order to try and achieve those goals, which is about quality of life and exacerbations.
And I would concur with that, and understanding that those that have exacerbations are more likely to have exacerbations and worse outcomes from a quality of life standpoint, admissions, healthcare utilization, and even mortality. Having said that, I think it's also just to be mindful to set the stage that we're really going to focus on the infectious component of that vicious vortex, if you will, but to understand that that's just the one of the components of what we need to tackle, looking at those domains of not only infection, and we're going to focus on pseudomonas, but inflammation, mucociliary clearance, and structural lung disease all need to be addressed and are really critical when we approach our patients, given this heterogeneous group that are inevitably the ones that show up in our clinics. Thank you.
Thank you. Farheen, you want to continue?
So just make sure. So it's essentially it's very essential to establish where the underlying microfibrillary causes such as immunoglobulin deficiency or alpha-1 antitrypsin is present, as this will, also guide management. But airway clearance regimen, exercise, and antibiotics in the following scenarios to attempt to eradicate Pseudomonas and MRSA, to suppress burden of chronic bacterial colonization and to treat exacerbations. And preventing an exacerbation is the key priority in management in these patients. get into another question. What is the most common bacteria that is isolated in sputum of patients with bronchiectasis?
Tiana, can you please show us the results? What are your thoughts on the importance of isolating Moraxella and H. influenza in patients with bronchiectasis, Dr. Chalmers and Dr. Aksamit? I know there are several studies that have been published in this. We know about the implications of pseudomonas, but I would love for you to elaborate on that.
Yeah, I think that go on, James, sorry.
No, Tim, I went first last time. You go ahead.
Okay. So I would just share that I think this is a consistent signal in the global community. Despite the heterogeneity, we understand that the isolation of Pseudomonas seems to be an independent marker of outcomes and prognosis. So I think that of all of those organisms, the Pseudomonas globally is the organism that is the dominant pathogen that we worry about. Having said that, there are some variations. So just for example, in the MBARC group, as I understand it, the second most common isolate is Haemophilus. And in the US registry, the second most common is Staph aureus. And there may even be geographic distributions on what the frequency of those organisms, Pseudomonas included. And I'll let James maybe talk about the MBARC experience with the geographic variations in these pathogens. James.
Yeah, it's absolutely fascinating. So in my hospital in Scotland, by far the most common pathogen is Haemophilus. And that's what we see in the MBARC is in Northern Europe. So the UK, Ireland, Scandinavia, France, these, non-typable Haemophilus is the most common. When we go to Southern Europe, there's almost no Haemophilus and it's all Pseudomonas and Staph, which is fascinating. I don't know why. Maybe climate, it may be background antibiotic use, it may be the differences in the etiology of the bronchiectasis, but it's fascinating. So consistently in every data set, Pseudomonas is the most severe, it's the driver of poor outcomes. Haemophilus is a bit more complex. Sometimes patients isolate Haemophilus and it seems to be a bystander rather than a major driver of disease. And that's borne out in the studies that it's not always consistently associated with poorer outcomes. But there's definitely patients who do very badly with Haemophilus. So I think there's quite a lot of diversity in that pathogen and the impact that it has on patients.
And I think it's worth just emphasizing that this is signal that's been demonstrated around the world in other registries as well. It's not just the European and North American experience, but now in Korea and India and China and the other registries have, for the most part, shown similar predominance of Pseudomonas being the important pathogen.
We tend to be very aggressive when we isolate Pseudomonas in the sputum in patients with bronchiectasis. How would you manage isolation of H. influenza in a bronchiectasis patient in a random sputum sample without necessarily having worsening symptoms, like no signs of exacerbation?
Go ahead, James.
Yeah, maybe I go first with this one. So an isolation of Haemophilus in a patient who's doing well with no major deterioration in symptoms, that probably describes 60% of my patients. And it doesn't necessarily require any kind of intervention. As you know, 70 to 80% of patients with bronchiectasis are infected with pathogens if you do a sputum culture. So that wouldn't necessarily require any kind of action. Where you'd be thinking about it would be if this is a patient who's having frequent exacerbations or has really severe symptoms. And in those situations, you may be thinking about either intensifying their treatment regimen with more airway clearance, or in some cases introducing prophylactic antibiotic therapy. And the first line for Haemophilus is usually an oral macrolide in our setting.
And I think that's an important point in understanding that if we think about Haemophilus, we understand, like all the pathogens, that it's just part of probably a very complex microbiota. So we have to understand what are we really going after. We understand that Pseudomonas, it appears to be an independent predictor of poor outcomes. So that is a marker for us there are signals, at least from the U.S. registry. We don't see as much Haemophilus, but there are pathogens like Stenotrophomonas that we see increasingly common and really resemble the course with Pseudomonas. So I think it is important for us as clinicians when we're seeing our patients, one is to collect sputums and then try to understand what that context is in the setting of the heterogeneity and the understanding that there is a complex microbiota that we're interacting with, as James says. Thank you.
Go ahead, Farheen. Thank you.
Sorry. So these are the isolates that we get out of, these are the gram-negative and gram-positive bacteria that is identified. Through some of my research, I actually found the non-typable, but I guess, it's based on your location. And then you also had some patients that came with gram-positive bacteria identified in sputum was MRSA. So which bacteria is associated with worse outcomes?
Tiana, can you just reveal the results? So 90% pick the right organism, which is Pseudomonas aeruginosa. Farheen, you want to just give a little bit more detail about this?
So I can't move to the next slide, just going back into why. And this is the importance of the study that we're talking about today. Sorry, my thing keeps freezing. There we go. So the identification of Pseudomonas is associated with, and this is why it has worse outcomes, because it has greater airway inflammation, worse symptoms and lung function, accelerated lung function decline, increased exacerbations in bronchiectasis. And as we spoke about earlier, this is the key point in taking care of these patients to reduce exacerbations, the increased risk for hospitalization and increased mortality in patients with Pseudomonas. So there was one retrospective study done by White et al. Outcomes of Pseudomonas eradication therapy in patients with non-cystic fibrosis bronchiectasis. And this is just some studies that were done before, some evidence done prior to PROMIS 1 and 2. This was published in 2012. It was an early aggressive eradication therapy of non-cystic fibrosis patients with Pseudomonas. It was an attempt to eradicate both Pseudomonas and MRSA on first identification in the course of directed antibiotics. As we know, the Pseudomonas does increase your mortality, increase your risk of recurrence of your exacerbation. So eradication protocols for non-CF patients may include IV antibiotics, inhaled antibiotics, or combination of both. And in the study, patients received either 3 months of oral ciprofloxacin or 2 weeks of IV regimen, either a combination of ceftaz or aminoglycoside. And then both groups received 3 months of nebulized colistin after systemic therapy was completed. And this is just the use of the antibiotics. Most patients, as I said, received ceftaz and aminoglycoside, but this was just the antibiotic regimen that was done during the study. And the results showed that early and aggressive use of antibiotics in the patient population led to Pseudomonas eradication in 80% of the patients. And they followed these patients up to 70 months and noted that 30% of them still had clearance maintained. It initially provided evidence that early Pseudomonas eradication in patients with non-CF may be affected and can be eradicated from high proportions of patients, which may lead to prolonged clearance and reduced exacerbation rates.
And this may be a chance if I could reach out or maybe give a shout out. Oh, you're gonna, never mind. Okay.
Sorry, my computer's freezing, but thank you, Dr. Aksamit. But we're also going to talk a little bit about the eradication treatment of Pseudomonas aeruginosa. It was a meta-analysis, and one of the authors is with us today, Dr. Chalmers. So the basis and the results of this meta-analysis was a primary outcome was the percentage of patients with negative Pseudomonas after 12 months after eradication treatment. Cystic fibrosis patients were excluded from the trial, from this meta-analysis. They found 212 unique studies that were identified. 6 single-center studies were selected, and 3 of them were retrospective. Of the 6 observational studies, they included 289 patients that were included in the meta-analysis. And they found that the eradication rate was in about 40% of patients. And then the combined systemic and inhaled antibiotic treatment was associated with higher eradication than systemic antibiotics alone in these patients. question. When are IV and inhaled antibiotics indicated in bronchiectasis?
Tiana, do you want to just show us the results? %94% chose treatment of acute exacerbation. So in the interest of time, let's move on and actually discuss the article. Thank you so much, Farheen.
Yeah. And Farheen, before we go on, can I just maybe go back to the eradication? And I'm going to again give a shout out to James and his recent meta-analysis and review that you were kind enough to share with us. We understand that pseudomonas is this independent predictor. And James, in your review, it was somewhere between about 30 and 50% eradication of pseudomonas at 12 months, as I understand it from the data. What I wanted to ask you, though, is one of the statements, as I understand it, and what I'm looking for you to comment on, is we're still uncertain about the impact on overall exacerbations, quality of life, and other moving forward. And knowing that pseudomonas is such a strong predictor, why didn't we see that signal show more strongly with the eradication strategies when you did your review?
Yeah, great question. So in fact, the study by White that was just referred to showed quite a significant reduction in exacerbations with eradication. They essentially halved the exacerbations in that study. The reason we're super cautious in the review about this is that there's no control group in these studies. They're just reports of what happened during clinical practice. And you and I have both been involved in studies where you randomize people to the placebo arm of a study. They had 2 or 3 exacerbations in the previous year. And in the placebo arm of a study, their exacerbations dropped by half. So we can't be sure that the exacerbation benefits that we're seeing in those observational studies are actually due to the eradication and not just a kind of regression to the mean effect. So there are a couple of randomized studies that are now either kicking off or quite far along doing this with a control group in bronchiectasis, and they'll give us the definitive answer as to whether there's an exacerbation effect of eradication. But you're right, the overall conclusion was you'll get rid of pseudomonas in about 40% of cases if you do this combination of systemic antibiotics and a nebulized antibiotic.
And I think it's important for our attendees to understand that in the previously published guidelines on non-cystic fibrosis bronchiectasis and the guidelines that are going to be updated soon, I think most of the guidelines favor using eradication strategies, even with the caveats that Dr. Chalmers had shared. And I don't know if you want to comment on that as well, James.
Yeah, so I mean, this is where guidelines struggle. When there's very little evidence, it's hard for guideline writers to know what to do. Most of the evidence for eradication comes from cystic fibrosis, and we're extrapolating to non-CF bronchiectasis that we would hope to see the same benefits. What that meta-analysis that was just discussed shows, though, is that eradication success is much lower in non-CF compared to CF. So in CF, studies report upwards of 80% clearance at 1 year. That's probably because we don't send enough sputum in bronchiectasis, so we don't pick up the pseudomonas early enough. And we think success of eradication is related to how quickly you get in there and tackle that pseudomonas. So it's the second shout out of the evening to send more sputum in your non-CF bronchiectasis.
I'm sorry, it looks like Farheen is having some technical issues.
Can everyone see my slides? We're good? Okay, perfect. So we're going to jump into the study that we're going to talk about, the inhaled colistin sodium in patients with bronchiectasis and Pseudomonas aeruginosa infection. So the results of the PROMIS 1 and 2 trials, there were two randomized double-blinded placebo-controlled trials, phase 3, assessing the safety and efficacy over 12 months. So the trial design is a phase 3 multicenter randomized double-blinded placebo parallel group interventional trials. Adult patients with bronchiectasis that were infected with Pseudomonas in hospitals in 12 countries in PROMIS 1 and 12 countries in PROMIS 2 trial. Patients either received inhaled colistin or they received a placebo via an inhaled nebulized device twice a day for up to 12 months.
Dr. Chalmers, I have
So
a
the
question
inclusion
at this point. You know, most of the drug trials, clinical trials, phase 3 trials, don't necessarily have a validation study plan. What were the concerns, or what was the thought process behind planning PROMIS 2?
I think
Great
they just
question.
wanted to.
Oh.
Go ahead. No, go ahead. I'm going to leave it to the experts.
So that the FDA requires substantial evidence of efficacy and safety, and usually that means 2 replicate studies so that you can have confidence in a phase 3 program that these results are reproducible. And so you'll have seen during the development of multiple drugs in bronchiectasis, going back to the inhaled Cipro studies, for example, or the aztreonam studies, they've always been two replica RCTs, and you'll see later on why that's really important, because if we want to be sure that something works, you want to see evidence that the results are reproducible.
So the inclusion criteria for the trial, patients had to be 18 years or older with CT-confirmed bronchiectasis, had to have a history of pseudomonas respiratory infection, positive sputum culture during the trial screening period. They had to have at least 2 pulmonary exacerbations requiring oral antibiotic or 1 exacerbation requiring IV antibiotic in the 12 months preceding the screening visit. They had to have an FEV1 greater than or equal to 25% of predicted, and the treatment of long-term macrolides was actually allowed during the study.
We discussed about this before, but I would love for Dr. Chalmers to comment about why patients who had a pre-bronchodilator FEV1 of less than 25% were excluded from the trial.
Yeah, so very, very quickly, this is really a safety issue. So the main issue that's been seen before with inhaled antibiotics is bronchospasm. Maybe less of an issue with colistin than with things like tobramycin and gentamicin. But the concern if somebody has very low lung function and then they develop bronchospasm is that could be a significant safety concern. So all of the inhaled antibiotic programs to date have had a lower limit of lung function for that reason.
Thank you.
Some exclusion criteria, if patients had bronchiectasis due to cystic fibrosis, they were currently treated for ABPA or microbacterial infection. If they had a change in their pulmonary treatment in 30 days before the screening visit, or a change in treatment between the screening visit and the random assignment. So the randomization was patients were randomly assigned 1-to-1 by an interactive web response system, and they should either receive the colistin or the placebo via the inhaled adaptive aerosolized delivery system twice a day for up to 12 months. They were stratified by site and stable use of macrolide antibiotics, and the masking was done by providing treatment and a placebo in an identical empty glass vial in which the same saline diluent was added. The intervention, so the inhaled adaptive aerosolized delivery device, it was a vibrating mesh nebulized device designed to adapt to changes in the patient's breathing pattern to optimize aerosolized delivery to the airways. And patients either received like the colistin or the placebo via the device seen in the image, and they'd receive it twice a day for up to 12 months. Some of the primary and secondary outcomes. So the primary outcome was the annual pulmonary exacerbation rate. And some secondary outcomes that came out of this was time to first exacerbation, quality of life using the St. George Respiratory Questionnaire score tool, change in the pseudomonas density, severe exacerbation rates, and the time to the first severe exacerbation. The result. So of the enrollment, the column on A is PROMIS 1 trial, and column B is the PROMIS 2 trial. In PROMIS 1, there was 538 patients that were initially screened, and by the end of the screening, 377 were randomly assigned, and of these, 123 completed the study for the intervention arm, and 129 completed study in the placebo arm. And on the same side, on the right-hand side was PROMIS 2. Of the 428 patients that were screened, 94 completed the intervention arm, and 89 completed the study were in the placebo arm. So some baseline characteristics of the patients, of the 377 that were randomly assigned, 177 to colistin and the 200 to placebo, and a modified to intention to treat population. And 176 were in the colistin group, 197 between 2017 to 2020. In PROMIS 2, we'll have to say that it was prematurely terminated due to the effects of the COVID-19 pandemic. But of the 287 that were randomly assigned, 152 were assigned to the colistin group, 135 assigned to the placebo group, and this was between 2018 and 2021. So just going over some of the other baseline characteristics, most of the patients were female, Caucasian. Most of them actually had, greater than 3 lobes affected. I thought that was interesting. And also the macrolide use. It seemed like the placebo group in PROMIS 1 trial had more of the macrolide use in the PROMIS 1 trial, and it seemed pretty similar in the PROMIS 2 trial. Some outcomes of the PROMIS 1 trial. So the primary outcomes, so 34% of the patients in the colistin group with a total of 89 exacerbations, and then 48% of patients in the placebo group with 163 exacerbations. So the annual exacerbation rate was 0.58 in the colistin group and 0.95 in the placebo group. The rate ratios of exacerbation in the colistin group relative to the placebo group was 0.61, which is statistically significant. Some secondary outcomes, the time to the first exacerbation was reduced by 41%, and there was a clinically relevant improvement in the patient's quality of life questionnaire with a 4.6-point improvement, with a 4-point minimum clinically important difference using that St. George questionnaire.
And Farheen, I may just take an opportunity, maybe we can take a break here and just 2 points that I think share with the group. The first is the second bulleted item under primary outcomes about the exacerbation or event rate. And this was mentioned by Dr. Chalmers earlier, that sometimes we get patients enrolled in these clinical studies, and there may be 2 or more exacerbations in the past year going into this. And then we have event rates that clearly decrease. And in this case, the placebo rate went down below 1, and the treatment arm was lower and more significant. But I think it's just important for us to be mindful that the event rates won't necessarily stay consistent. And in fact, it's consistently inconsistent in that those rates will decrease just being part of the study. What I wanted to just maybe get a little wonky with Dr. Chalmers about clinical trial design, that the primary endpoint here was annual exacerbation rate. And when we look at some of the other studies in bronchiectasis, sometimes it's time to first exacerbation. And James, how do you approach when you're thinking about trial design? What would your preference be on annualized exacerbation rate, time to first exacerbation, or even frequency of exacerbation?
Yeah, great question. I think from a clinical perspective, what people want to know is this going to reduce the exacerbation rate? Because most of the time we're going to be using these drugs in people that have recurrent exacerbations. And so we're looking for an effect over the long term. I certainly use inhaled antibiotics like colistin long term in my patients. So the time to first exacerbation, the statisticians love it because it's a very clean endpoint. It's one event in time. So it's very easy to measure, and you don't have the complexity of when somebody gets another course of antibiotics, is that the same exacerbation or a different one? So the statisticians love time to first, but I think we as clinicians are much more comfortable with the idea of, okay, I've got a patient with 3 exacerbations, I want to drop that down to 2 or 1. And so frequency, I think, for me is the most persuasive endpoint.
And I say that just to raise awareness for the group that some of the other studies with the DPP-1 inhibitors, for example, use time to first exacerbation. So as you're looking and thinking about these results when they get published, I think it is something to be mindful of, as Dr. Chalmers says. Thank you.
Yeah, I mean, I can share our experience that we had a workshop. I think you were with us, Tim, with the FDA in 2018 when very much the trial design favor was to use time to first, and the clinicians overcame the statisticians on that day, and since then the preferred regulatory endpoint in the US and Europe has been frequency of exacerbations. So you'll see with the upcoming Aspen study, for example, frequency of exacerbations is the primary there as well.
Yeah, and I say that understanding with the recently published Airleaf trial, which uses primarily time to first exacerbation. So the point is, it's just a little bit of a mix in that. I think it's something that we need to be mindful for all the reasons that you've shared with us.
Yeah, that's a very good point. So where time to first is very useful is in a phase 2 study where you're trying to get proof of concept with a drug, and you maybe treat people for a shorter time period, like 3 months or 6 months. The Airleaf study was a minimum of 6 months. So there, patients don't have as much time to have recurrent events, and so time to first can be a nice pointer to what you might see in phase 3.
All right, Farheen.
Outcomes of the PROMIS-2 trial. 47% of patients had a total of 111 exacerbations. When the placebo group, there was a total of 98 exacerbations, which was equivalent about 47%. The annualized rates of exacerbation were essentially identical in the experimental and control arms. PROMIS-2 did not reach a statistical significance on the primary endpoint, and the median time to the first exacerbation was 53 days longer in the colistin group compared to the placebo group. And in the secondary outcomes, there was improvement in quality of life in the treatment group, but the placebo group also had improvement during the study. So this is just a table going over what the primary and secondary endpoints that I had mentioned before between PROMIS-1 and PROMIS-2. PROMIS-1 did have a statistical significance, whereas PROMIS-2 did not. However, it was prematurely ended due to the COVID pandemic. So primary endpoints over time. This PROMIS-1 is on the top and PROMIS-2 is on the bottom. Colistin is on the left and placebo group is on the right. The blue dots represent everything before the COVID-19 pandemic, and each dot represents an exacerbation rate. Anything that goes beyond the gray vertical line is post-pandemic. So it's just interesting to see, like, due to the COVID pandemic, it had an effect on both PROMIS-1 and PROMIS-2, but more on PROMIS-2 trial. So the pre-COVID-19 on the intervention and the placebo groups, the number of patients with exacerbations were about the same. Comparison to survival curves, the number of patients with the St. George Respiratory was about the same on both. And then hospitalizations for pulmonary exacerbation annual rates was a little less on the colistin group. And then the number of patients with annual exacerbations was 127 in the colistin group and 109 in the placebo group. This was all pre-COVID in the PROMIS-2 trial. Some adverse effects that were noted in the PROMIS-1 trial. So 142% in the colistin group, 142 patients, 81% of the patients in colistin group and 81% in the placebo group had at least one treatment emergent adverse event, most of which were mild or moderate in severity. And then 45% were reported in the colistin group compared to the 67 in the placebo group. This is all in the PROMIS-1 trial. 2 patients, one in each group, died during the study. The deaths were considered by investigators to be unrelated to the study treatment, and the bronchoscopy was reported in 3% of the colistin group and 1% of the placebo group. And in the PROMIS-2 trial, 81% of patients in the colistin group and 77 had at least one adverse event that were mild or moderate, and serious events in 18% were reported in the colistin group and 13% were reported in the placebo group. 5 patients died during the study, 3 patients in the colistin group and 2 patients in the placebo group. Again, these were not considered by the study investigator to be related to the study treatment. And then bronchospasm was reported and 5% in the clustering group and 2% in the placebo group. So this is just a study summarizing what type of adverse events that they mentioned: ineffective exacerbation, cough, dyspnea, hemoptysis, sputum increase, diarrhea, headache, and COVID-19, which was actually seen in none of the patients in PROMIS 1, and in PROMIS 2, 5% and 3%. Some other findings to be noted. So the in vitro resistance was also uncommon in the study. There were 3 patients in PROMIS 1 and 9 patients in PROMIS 2. And in the PROMIS 1 trial, the adherence was 87% in the clustering group and 87% in both the placebo group. And it was also similar in PROMIS 2. They had pretty good adherence with the patients. So jumping into the discussion of the trial. So as we know that exacerbation reduction is a key clinical goal in patients in management of bronchiectasis, as it has, when your patients have multiple exacerbations, it increases hospitalizations, increases IV antibiotic use, and increases mortality. So bacterial load is relevant in inflammation and exacerbation risks and symptoms, and reducing bacterial load reduces the risk of future exacerbations. There are a few additional therapies that are proven to reduce exacerbations in bronchiectasis, and then colistin was administered continuously for 12 months rather than a cyclical method, and this might explain the consistency and the sustained improvement in symptoms observed in both studies. So I think some areas that need future investigation. So a randomized trial of pseudomonas eradication in bronchiectasis is needed. In the absence of such trial, the best available evidence is informed clinical practice, and to inform clinical trial design comes from observational studies. Like we had mentioned before, I mean, they were the meta-analysis that was done by Dr. Chalmers, but I think maybe getting some randomized control trials more on eradication of pseudomonas. We have a lot of data on cystic fibrosis, but maybe getting a little more on non-cystic fibrosis patients. But yeah. Thank you.
Thank you, Farheen. So I think the biggest question that comes up when you look at the results between PROMIS 1 and PROMIS 2 is, why are the results of PROMIS 2 so different from PROMIS 1? Why weren't we able to replicate it? So I think the best person to answer that question would be Dr. Chalmers and Dr. Aksamit. Please chime in terms of your thoughts as well.
Yeah, thank you very much, and really well presented. So thank you very much for presenting that paper. We did some exploratory analysis, and you saw some of the data presented there with those nice plots showing the number of patients that were enrolled during the pandemic versus those that weren't enrolled during the pandemic. PROMIS 2 was heavily impacted by the COVID pandemic. And we all know, firstly, exacerbations went down a lot during the pandemic. It's much harder to prevent things that aren't going to happen. But also clinical trial conduct was heavily disrupted during the pandemic. Yeah, I wasn't doing clinical trials in 2020 and 2021. I was on the front line seeing people with COVID. And so even the people delivering the trials were different. And that's seen in PROMIS, in that the vast majority of visits went virtual. Patients were reporting exacerbations in a different way. So I think we've got enough to believe that there may have been essentially different experimental conditions during the COVID pandemic compared to before. I don't know if anybody on the call is a lab scientist, but if you're repeating an experiment, the first rule is keep all of your conditions the same. And in this situation, all of the conditions in PROMIS 2 were different to the conditions in PROMIS 1. So that may well explain a lot of it. We do have to acknowledge that we have seen inconsistent results before with other inhaled antibiotics. And so the other thing I would say is we don't yet know, I think inhaled antibiotics work, and I think inhaled colistins works, but it doesn't work in everybody. And we don't yet know what is the biomarker or the clinical characteristic that picks the responder patient. And so I think that's also plays into some of the inconsistency that we see. I'd love to hear what Tim's take on that is.
Yeah, I would certainly agree with that. And I think there was some subgroup analysis presented in this paper, and in particular in the supplement, separating out the pre and post-COVID enrollments in PROMIS 2. And I think that illustrates very effectively that the signal of benefit was present before COVID, but after COVID, and primarily, again, as Dr. Chalmers said, that the event rate in the placebo group and the did not or went down substantially, and really, I think, contributed to some of that lack of signal. And that's been an observation that's been seen in other phase 3 clinical trials. So it becomes really important to be as consistent as we can, especially across these heterogeneous groups of individuals with non-CF bronchiectasis. I think we've all been burned doing clinical trials in this way, and I think that just underscores the need to be vigilant about this. But if I encourage those on the call to not only look at the primary publication, but some very nice illustrated forest plots looking at the pre and post COVID signals. And James, I don't know if you want to comment on that as well.
Absolutely. So we took out, basically we pretended that the pandemic never happened. So we froze the study at the point at which the pandemic broke out or the WHO declared the pandemic in March 2020. And if you look at the data before then, there's a 30% reduction in exacerbations in the CMS, the colistin arm. So that would suggest even in PROMIS 2, there was a benefit that things went awry after March 2020. And, you know, all of us know lots of things went awry after March 2020.
And I might also just take the opportunity and just share that, just as Dr. Chalmers says, even though we don't have FDA approval or we haven't met primary endpoints in both two of the phase 3 studies for the previous inhaled antibiotics, we all use antibiotics. And to put this in perspective, in the US registry, for those individuals with non-CF bronchiectasis and are having frequent exacerbations, 2 or more per year, about a third of those individuals are seeing some inhaled antibiotics. My only point is that we all use it and use it regularly, and exactly what we use, how we use it, whether it's colistin or tobramycin here in the States primarily, and then whether it's continuous or intermittent. I'll let James comment on that. And in that same regard, I would really encourage the attendees here. There was a beautiful review in another systematic review and meta-analysis in CHEST last year that Dr. Chalmers and colleagues put together, looking at inhaled antibiotics with the previous studies looking at Orbit, Respire, and others. And James, maybe you can comment on that, because I think that's a very important paper and really highlights what we all really do in real life. Thank you.
Yeah, absolutely. So that's a study by Ricardo Cordero and Ha-Young Choi, 2 brilliant young scientists working in bronchiectasis. And they did a meta-analysis of 20 studies. So we've now got 20 studies of inhaled antibiotics in bronchiectasis. And this is not just colistin, but it's tobramycin as well, the Cipro studies, one study with gentamicin. And it confirms that inhaled antibiotics work. You know, the reason why so many people in the US registry and the European registry use them is because we do see that they work. And the meta-analysis showed a 20% reduction in exacerbations, approximately a 50% reduction in severe exacerbations. So it prevents patients coming into hospital. And there's also an effect on quality of life. So I think that's an important study in that it confirms what we feel clinically, which is that they do work. The problem is they don't work in everybody. So my practice is to give patients a trial of these when they've got particularly chronic pseudomonas infection and frequent exacerbations, but to discontinue them if the patients don't experience an exacerbation benefit over between 6 to 12 months.
And I think another unique feature of the inhaled antibiotic studies, including the PROMIS 1, PROMIS 2, and I'm going to ask James about when these studies go to the FDA. The other side of the coin, of course, is the safety factor. And one of those dimensions is, are we developing resistant organisms? And our experience, certainly with inhaled tobramycin, is that the resistance rates do increase substantially when we're using inhaled tobramycin. And it was interesting in the PROMIS 1 study that the resistance development was relatively low, less than 3%. That rate increased to just, as I understand it, about 9% in PROMIS 2. And James, maybe you can comment on, understanding not only are these effective, but from the other side of the coin, and whether you're doing this in your clinical practice or you're going to the regulatory agency, about the safety factors, specifically the resistance issues.
Yeah, so I would love to see this approved by regulatory authorities. I think previous inhaled antibiotics have been declined, not because people don't believe that they work, but because of concerns about resistance and safety. And colistin seems to have a big advantage in that area. So it's much harder for organisms to develop resistance to colistin than to other antibiotics. My friend who's a microbiologist described colistin as like soap in its mechanism of action. It's very hard for organisms to develop resistance because of the way it works. And you see that in the trials. It's rare that Pseudomonas develops resistance. And the bronchospasm rates were really low in this study, unlike the 20% or so that we've seen in previous studies with tobramycin. And that's also reflected in data from CF. Aminoglycosides seem to be more irritant to the airways than polymyxins. And so there's a lot of reasons from this study beyond the efficacy to think colistin is a safe option in terms of resistance and tolerability.
Dr. Aksamit, I have a question. Here in the United States, we tend to get inhaled tobramycin a lot easier compared to inhaled colistin. Will the results of the study allow for more easy access, do you think?
Yeah, so it's a great question, Divya. The issue is, is this enough to cross the finish line for regulatory approval through the FDA? And unfortunately, as has been presented, the second PROMIS 2 didn't, with intention to treat analysis, meet primary endpoints. The question is, with the very sophisticated analysis done pre and post COVID and all the other factors, is that going to be enough to get past the regulatory agency and have this approved? And I've gotten to the point of not trying to guess what regulatory agencies are going to decide. They have a mind of their own. So if it does get approved, which I don't know is given by any stretch, I think it would be easier to get. And currently, at least in the States, and I'm not sure what the European experience is, we use this off-the-shelf IV, and usually the access is moderate. I don't want to say easy, but I don't want to say difficult, in contrast to many other medications, including but not limited to things like aztreonam and that sort of thing. And James, what's your take on that?
Yeah, so colistin is much more available in Europe. It's the most widely used inhaled antibiotic across almost all of the European countries. It's used off-label because, of course, there's nothing that has a specific label in Europe or the US for bronchiectasis, but it's relatively easy to prescribe. One of the challenges, though, is getting good quality nebulizers, and it's important to remember here that actually this trial was a test of a drug-device combination. So it wasn't just the drug, but also a mesh nebulizer, which allows patients to take the medication rapidly. And so I know we've only got a little bit of time left, but I'll just stress that these drugs do come with a degree of treatment burden. And we know from studies that adherence to these drugs long-term can be a challenge. So actually providing a good quality nebulizer that delivers the drug rapidly can make a big difference in terms of patients persisting with the therapy. And that is that is sometimes more of a challenge for us in the UK, where our practice is getting access to those good nebulizers.
And that's a great point, I think, worth emphasizing, and that the estimated treatment burden for using the nebulizer treatment for the PROMIS 1, PROMIS 2 studies are 3 to 4 minutes, which is a fraction of what I think our experience here in the States is with most other nebulizers, whether it's with inhaled antibiotics or even hypertonic saline, for example. And one of the reasons why there was such interest in dried powder in antibiotics, none of which have, again, crossed the finish line from a Cipro, and it's not accessible from a Toby standpoint here in the US. But treatment burden is hugely important, as Dr. Chalmers said, and this is with this study in particular with the I-Neb, that 3 to 4 minutes is doable for patients and really does impact in a favorable way the treatment burden.
We have a couple of questions in the chat. So the first one is, will the fact that only one supplier or two globally for colistin or the I-Neb be a rate limiting factor in terms of prescribing for patients?
Short answer is yes, but I'll defer to James.
Yeah, I mean, I think it is a limiting factor in terms of availability of the nebulizer in particular, because actually in the UK we're having difficulties in obtaining that nebulizer. I believe it's been discontinued, and so there may well need to be a replacement for that nebulizer coming forward. So I think that is a challenge. The fact that there's only one supplier for the drug, if it's approved, is not a problem. I mean, for most licensed drugs, there is a single supplier. But I think there is a particular issue with the nebulizer currently.
Yeah, so I think one of this is a question by Dr. Hassan. He was one of the PIs on the PROMIS 2 trial, and the patients had to draw the drug from a vial and had to inject it with a needle into the I-Neb. There was a lot of heavy education training and troubleshooting for the patients. So do you see this improve by manufacturers in providing colistin in an easier way? Is his question.
I think from a process standpoint,
Yeah,
always part of the equation and really is an important factor in, again, trying to minimize and treatment burden to try to optimize the efficiency and ease with which this is delivered. So anything that we can do in that methodology or that process will have a favorable impact. James?
Yeah, I was going to say this isn't a unique issue with colistin. All of the drugs come in vials, or all of the liquid drugs come in vials that need to be put into the nebulizer and need to be prepared. So this is unfortunately an issue with all of the inhaled antibiotics. As Tim said earlier, is why it's such a shame the dry powders didn't work out, because this is a challenge for some patients who have, for example, dexterity issues. You know, my patients with rheumatoid-associated bronchiectasis can struggle with vials, but unfortunately there isn't an easy solution. The liquid has to get into the nebulizer somehow.
Dr. Barker had another question. He says that the colistin studies are essentially all other inhaled antibiotic studies. The inclusion criteria included 2 or greater exacerbations in the previous year. Why do European, British, and Australian guidelines recommend inhaled antibiotics for greater than 3 exacerbations per year?
I would defer to my European colleagues.
Yeah. Which fool wrote those guidelines, Tim? I don't know. That was No, I can give you insight into those discussions, that big, really difficult discussions actually back in 2017 when writing those guidelines. And it's a balance between wanting to prevent exacerbations and recommending too widespread use of prophylactic antibiotics, and therefore being criticized for driving resistance. I can tell you the guidelines say 3. I don't religiously practice that. In many cases, will prescribe macrolide or inhaled antibiotics to people who've got 1 exacerbation but very severe symptoms, because those patients are at great risk of things happening in the future. keep your eyes out for what may happen with guidelines in the future, because yeah, that what is currently written in the guidelines doesn't necessarily reflect my practice.
Yeah, and I might just on a squishy level just share that as Dr. Chalmers mentioned earlier, that with virtually every phase 2, phase 3 study, that as placebo event rate requirements are 2 or 3 per year going into this, they almost always go down, and even to the point of about 1 per year. So my only point is that there is a argument to be made that if you're giving standard of care and doing all the other components of care for bronchiectasis patients, that going into this at 2 per year may actually drop back down to 1, and you may have some favorable. Whereas if you're starting with 3 or more per year, then I think it's far more likely that you're going to have an event rate. And the only exception I would share that's been presented at a meeting but not yet published, is the HSK phase 2 study by HISCO, that their placebo event rate did not go down from 2. It stayed exactly the same. And there's not been any other phase 2, phase 3 study that I'm aware of that hasn't had a decrease in the placebo event rate. And I don't know, James, if you want to comment on that.
Yeah, I know we're running out of time, but I'm going to give you a really important concept for managing your patients, regardless of inhaled antibiotics. I try to think not about just the number of exacerbations that they've had. Sorry, I'm having an exacerbation here. Not just the number of exacerbations that they have. I think about risk of exacerbation. So if you've got a patient who had 2 exacerbations in the last year, but they come into your clinic and say, I'm as well as I've ever been, I feel great, they've got idiopathic bronchiectasis, they don't have pseudomonas, that person would be eligible for the study, but they're probably not going to have an exacerbation next year because they're doing well. Somebody comes into your clinic and said, I had 2 exacerbations in the last year, they've got pseudomonas, they've got rheumatoid-associated bronchiectasis, which we know is associated with worse prognosis, they're coughing up lots of purulent sputum, that patient's going to do really badly next year. So it's not just about the number of exacerbations, it's about trying to think about individualized risk. And one of the things that our registries have done really well is tell us which patients to be worried about. And so that's the way I try to think about every patient that I see, is not just that magic number of 1, 2, or 3, but what's their individualized risk. And I'd obviously be much more aggressive with the second patient than the first.
We're actually out of time, but I have one final question. Does this study justify daily tobramycin as opposed to cyclical tobramycin in patients?
Can I jump in and say, yes, I've been doing daily tobramycin for years. I don't understand why we cycle. Patients feel worse in the off months, and there's no evidence that it prevents resistance. But I obviously have quite strong feelings on this.
Right, and there's not any data to support that. And my only other caveat is that I think we're looking at alternative strategies, even not 28 on, 28 off, and maybe 14 on, 14 off as an alternative, just trying to, again, mitigate some of that disease burden, but continuous use is not an unreasonable strategy.
Thank you so much, everybody, Dr. Surthie, Dr. Chalmers, Dr. Aksamit, for this wonderful session. I hope everyone found it as educational as I did. Thank you to Tiana from ATS for helping us organize these sessions and seamlessly navigating through Zoom. I wish everybody a wonderful day. Keep a lookout for more of such fine sessions in the future. Thank you.